As you know, this is another one of the countries that have been badly shaken with this pandemic. And then we will have another very distinguished speaker, Professor Barbara Meyer from Vienna in Austria, although she's talking to us from Salzburg. Is that right, Barbara? Now, Dr. Barbara is the head of Obstetrics and Gynecology, Department of the General Hospital in Vienna, Austria. And importantly, this hospital is a designated center for all the SARS-CoV-2 infected delivering for the obstetrics. And so her title is going to be a report on the SARS-CoV-2 management, and that's really the experience of 16 months from the Obstetrics and Gynecology Department of this General Hospital, which is the designated center for SARS in Vienna. And then we have a distinguished Dr. Sashka, who actually was in ways the coordinated to help me in coordinating and bringing this. Thank you, so Dr. Sashka, for your help in helping us put this together into bringing some of the speakers, including we had our colleagues from over. So Dr. Sashka, from Belgium, is that right? And she is from the Free University of Brussels, the Department of Obstetrics and Gynecology. And she's going to speak on the impact of COVID-19 and healthcare in obstetrics and gynecology in Belgium. So these are the three speakers. And so now, can I hand over, can I offer Usha, Dr. Usha? Professor Usha, will you start? And then our second speaker will be Professor Barbara, and third, Dr. Shashka.
Sure, sir.
Okay.
Thank you very much.
Sorry to interrupt everyone. I have posted a YouTube live link in the chat box as well. So there is a live streaming of this meeting on YouTube. And at the same link, you will be able to access the recording even later on. So in case there are any of your friends or colleagues who would like to watch this on YouTube or are unable to log into Zoom, you can copy that link from the chat box and forward it to them on email or on WhatsApp, and many more can join the meeting. And later on, you will be able to access the recording of this meeting as well. So sorry, Dr. Usha, back to you. You may share.
Yes, I forgot to mention that there are through the YouTube, it's also being live streamed, and so many of the colleagues will be participating through the YouTube. I also wanted to welcome Vivek Madi. He's also an obstetrician. And okay, over to you, Usha.
Thank you very much, sir, for my being part of this webinar. I will now share my talk. Happy Sunday to you all. So the topic of the day that I have chosen is the department that never sleeps, OBGYN during the COVID pandemic. This is Sri Ramachandra Medical College, Chennai, the organization that I've been working for the past 26 years, very close to my heart. So this is a reality story that we will probably be sharing for generations. A bolt from the blue, an unknown enemy just descends on not so fine one morning. What did we all think, the healthcare and the public? We thought COVID is just like any other virus. Will just go away. We have had several viruses so far, and this is nothing different. And why are people making such a hype about this? This is what was the initial response. But then we were sadly mistaken. The healthcare was taken by surprise. And what happened because of this? We realized that this revealed the status of unpreparedness at all levels of healthcare across the globe. Priorities were set. There was mixed feelings, mixed emotions, uncertainties among the healthcare. Priorities were set on ensuring patients and healthcare workers' safety. I need to mention at this point of time that our Chancellor, Mr. Venkatachalam, a man of very few words, walked into our hospital and he sat there, and I remember his words. He said, just go ahead. He spoke to the leaders of our organization. He said, just go ahead and do what you can, but I want my family to be safe. And that began the pandemic. This
Dr. Usha, one moment. Could you switch on your video, please, so that the audience can see you, all our participants?
Sure, ma'am.
Yeah, thank you.
Then the first primary objective became how can we avoid COVID infection among the healthcare workers? Everybody was scared. Everyone was nervous. We didn't know what exactly we need to be doing. We required a fast restructuring in order to provide for COVID-related care. In an exceptionally unprecedented speed, we had to manage three kinds of patients. One, who are COVID negative, two, who are turned to be positive, and the third category where they are suspects because they come as an obstetric emergency with either a rupture of membranes or they are well in labor. And we had to make all these infrastructure changes. So we had to have dedicated spaces for COVID-19 cases with reinforced measures in an unbelievable pace. I still remember we were speaking to the general manager of infrastructure and he had no clue as to what we were asking. And we all sat together and got so many things done at such a fast pace. We had to think in unison in crisis because this was a very exceptional, strange situation where no one knew exactly what was actually happening. Then we realized that there was no ready available solutions for this kind of a situation. We also had the reality staring at our faces. Other than wearing masks in the operating theater, did we ever wear masks outside? We found that we had the finite nature of resources in terms of personal protective equipments, tests, and manpower, and we need to really work on this in a big, large way. The entire staff required to be trained all about COVID, procedures of donning, doffing, the standard latest guidelines for disposal of biomedical waste, and we went virtual training for the doctors, nurses, and the hospital infection control team played a huge pivotal role in this. But how do we train these housekeeping? They have no access to virtual training. We had to take them onto a huge outside in our campus, and we had to tell them how exactly they should be wearing gloves, how should they protect themselves, how should they handle biomedical waste. These were great challenges, but then they really lived up to whatever we expected them to be. So our hospital, we have two labor wards. We have one corporate hospital and we have one university hospital having around 5,000 births per year, a postpartum and an antenatal ward. So it's double trouble. We had a very planned process in place for decades, a gynecology ward with elective surgeries, post-operative ward, including oncology, and various things that were going on so very smoothly that took a jolt abruptly. I don't know what exactly made me do this. This was just soon after I took charge as the head that this COVID came and landed on my head. So this was the first department to call off elective admissions. And we decided that we'll watch the situation closely. As early February 2020, I called for a meeting with all the unit heads. And then we decided that we will just call off all elective admissions and do only the emergencies. And I have to tell you, I'm so proud of my department because each and every person just stood by me and we all stood shoulder to shoulder to handle every problem that we had. All our academic sessions got virtual. Students were getting nervous. They were getting close to their exams. They were very apprehensive. There was no patient contact. We made our postgraduates become standardized patients. We got a lot of interns who became standardized patients, and interns did not have patient material to be taken care of. So we had to really put so much of spirit into the students because they were so apprehensive, and we had to talk to almost each and every one of them. And then came the national lockdown from March 23rd in view of the rapidly progressing epidemic. So evening clinics closed down, family welfare got shut down, infertility services got shut down, and we called out all the elective and non-essential activities, both medical and surgical. We got through consults through video consultation. So this was a new way of doctor-patient communication that we started. But then the university hospital patients who had financial constraints were largely hit because only those affordable could go ahead and have these, because they had no access and they did not know how to go ahead with these telemedicine. Waiting rooms were arranged, allowing distancing. We did have problems because attenders wanted to walk in, especially during the first wave. They did not understand what this all hype was about. Face masks and hand sanitizers made their entry, and they made their entry to stay for a long time. And we needed to educate a large number of patients and family on the importance of these. All healthcare workers and patients were told that they have to wear the mask all times. And it was a challenge because they would want to sit huddled together, especially the interns, the postgraduates, the younger residents, especially during the lunch. And it would be like I'm policing them all the time to see what exactly they are doing, especially during the lunch breaks in the labor ward. I must say this, with the help of my tailor and driver, one day I was just saying, I need something. We made these labor barriers. Necessity is the mother of invention. And within 2 days, my tailor had 100 of these, which we use even to this day, because this is something that the patient has. And in the second stage, when she is training, she's screaming, the masks is off of nose and mouth, this acts as a great barrier. We introduced the sneeze guards in this consultation room, and it became a different kind of doctor-patient interaction. We no longer could pat our the shoulders of our patients. We had to be at a distance, and we had to exude all that positivity and that confidence in them from a distance. It was a different experience altogether. We have 6 units. Then we realized that we will use manpower in a very judicious manner. We clubbed all the doctors across our units in our department. We channelized nursing towards the COVID duties because they had to move to the COVID wards, and all related support services went on rotation. So we had to effectively use our manpower. We found that we were overusing N95 masks. This is what someone would look like in an outpatient department, because they were so scared to even do anything without the gloves or the face shield, the visors. And gradually, slowly, when things settled down, we came off all these, and then we decided what exactly is required to be seeing a patient in an OPD. The overuse of surgical gowns and the gloves continued for quite some time, especially in the first wave. Handling the anesthesiologist was a daily battle. Anytime we take a case, we would have to answer hundreds of millions of questions, and they would say so many things, and we would be keeping our fingers and toes crossed whether they're going to cancel or send any patient back. And we had to convert 2 operating theaters into negative pressure facilities. We created a team of doctors to handle COVID positive patients, and we made rosters. We gave incentives to those who were involved in the direct care of COVID patients. And I remember having so many virtual meetings with them to just reassure and then tell them that these are all the things that you need to go ahead and do, and not to get apprehensive or nervous about handling COVID positive patients. During the first wave, we were attending only to our own book patients because there was a huge exodus. There was a shutdown of almost all the private nursing homes, except the government and few of the larger corporate hospitals, and they would all start moving and knocking our doors. So we were looking at only our own book patients and referred emergencies during the first wave. There was a huge crunch of manpower. There's huge absenteeism, especially in nursing, the pregnant staff. And then we had to use the services of operating theater nurses because we closed down a lot of elective operating theaters. So we had to use them. We had to teach them what exactly they needed to be doing in the labor room. So all this was happening at a very, very fast pace. And then the vaccines arrived in January 2021. The government made it possible for all healthcare workers to be taking it. And then there came the question of vaccine hesitancy. It was so freely available, but the nurses were not willing, and even doctors and some of the senior doctors in my department were also so skeptical and hesitant about taking this. So we made it mandatory in our department and said, except those who are pregnant, everybody else is going to be vaccinated, and had to take the iron hand for this. Vaccination got approved for the lactating women and yet to get approval for pregnant women. And we are now at a huge vaccination drive because we know it's not so easy to convince people. We tell the patients, if your mother is vaccinated, she can be your attender. Please get her to vaccinate. And we plead, we beg, we do all kinds of things to make sure that they get vaccinated. But ultimately, I need to tell you, after this many long period of pandemic, it's brought so much of psychosocial impact on patients, the healthcare workers. These are my interns, my postgraduates, my assistants in my unit, the behavioral changes, apprehension, agitation, so many things. And so we need to keep up the spirits and with the positive thoughts. Really, really, really trying situations. Can never forget what actually a pandemic is. We have heard stories of pandemic, but imagine to go through a pandemic. I don't think it's a pleasant thing at all. So I'd like to end saying it's now an absolutely new experience, huge responsibility, instilling positivity in every person in the department across all cadres, whether it is nursing, security, housekeeping, ward technicians, everyone else, without testing positive. Life has changed for the entire globe. Health has become the greatest priority. I know we can't stop the waves, but we have to learn how to surf. This is how it was once upon a time. Seems like a distant dream. And hope, the lost time and what we actually took for granted, that wonderful life comes back soon. Thank you all for this opportunity.
Thank you, Professor Usha. Usha, thank you very much for that report on the department that never sleeps. And it was interesting and wonderful to see something positive come out of this from what you've told us, bringing all together. And we all in unison with you in that we will all come out of this together successfully. That's the solidarity that our program brings for the last 15 or 16 months that this has been going on. Now, let me now introduce to you, I've already introduced, but the next speaker is Professor Barbara Meyer from Vienna in Austria, and she's going to speak on a report on the SARS-CoV management, a 16 months report on obstetrics and gynecology department of the General Hospital that was the designated center for COVID patients. Over to you, Barbara, Professor Barbara Meyer.
Thank you so much for the nice introduction. Can you all see my presentation?
Well, yes, I can see it.
Please go ahead.
Yes.
Yes. We were the hospital designated in Vienna. Vienna is a 2 million people city. They had the capital city of Austria. We were designated for COVID SARS-CoV-2 management for all delivering women in Vienna. This meant a big challenge for our department, especially. I cannot. Now, this was a big challenge for our department because we had to make sure to give the possibility to all delivering women with or without SARS-CoV-2 positivity, and especially for the deceased women. In November 13th, 2020, Austria was on the 4th position of new infections in Europe. And perhaps you have seen and you have heard that Italy, that France was in a very, very bad situation. And we saw the pictures and we saw how many people died from COVID-19. And so it meant a big challenge for us all. We began dealing with COVID-19 in our Obgyn department in March 2020. So we have very much experience, the most experience in Austria, I guess. So we had a guideline for our hospital and other hospitals in Vienna, Obgyn departments, a guideline. And here you see the guideline is in German, of course. But what I want to draw your attention, this is version 11. This is work in progress. The more we know, the more experience we have, the more studies on COVID-19 in obstetrics is out, the more we can really deal with it more adequately. So we also published, and this is the next publication, with a 1-year experience into SARS-CoV-2 pandemic perinatal outcome and data of transmission of 116 pregnant women. So you see here the total of hospitalized women you delivered while the women delivered while they were SARS-CoV-2 positive, and women discharged after having gone through SARS-CoV-2 disease. So the characteristic of the population was, you see what I want to draw your attention not to all the dimensions which we examined, but you see that 6.1 of the SARS-CoV-2 positive needed intubation. 7% needed intensive care. 1 woman needed ECMO and non-invasive ventilation also, and 1 woman died. So what we learn about that is the pregnant women are a risk population. What we did not know, March 2020, we thought we are dealing with young women. Young women are not as much as risk as, for instance, men or older women. We thought younger women are not, pregnant young women are not in the risk group. But this was totally wrong. Pregnant women are a risk group for SARS-CoV-2 disease, and also very vulnerable to have bad outcomes. Also, we had a 3 times higher rate of preterm birth before 34 weeks, 8.2%. This is in Austria a very high rate for preterm birth. Also, it was for the newborns not so easy. 2 newborns were SARS-CoV-2 positive. So the summary of results of our registry of SARS-CoV-2 infected and diseased women was: most women were asymptomatic, 70%. 19.5% of women tested positive for SARS-CoV-2 had to be hospitalized, 1/5 of all women. 22.9% of women with symptoms had to be transferred to an intensive care unit. That is 6.9% of women tested positive for SARS-CoV-2. Of all women tested positive for SARS-CoV-2, 8.6% were in need of oxygen. 5.2% had to be intubated. 2 newborns tested positive for SARS-CoV-2 postpartum. 1 newborn was critically ill. The C-section rate mounted up to 44.9%. We are a perinatal center and we have a usual C-section rate of 27-28%, although being a perinatal center and dealing with all heavily demanding, difficult birth. The preterm rate beyond 34 weeks of gestation was 8.2%. To date, we have no virus detection in amniotic fluid, in blood of umbilical cord, in breast milk, or in the placenta. What do we actually know to date? What is the implication of that knowledge we have gained? Pregnant women are 3 times more at risk to be transferred to an intensive care unit as are the same women in the same age group. Pregnant women are 3 times more at risk to need intubation. The risk of preterm birth is 3 times higher than in the population of pregnant women without a SARS-CoV-19 infection. Therefore, they have to be seen as a group and they should get prioritized in the national vaccination program. And Vienna did it. Challenges we still face. There is the problem with the quality of data and the problem with data interpretation. Most important are adequate comparable groups. In many studies, pregnant women were compared to general population or general population with COVID-19 disease instead of women of the same age group. Immediate establishment of a registry is highly necessary to gather structured data. In Austria, we have now a birth registry which also deals with SARS-CoV-2 infected delivering women. There has to be the inclusion of pregnant women in appropriate studies from the very beginning in order to minimize negative impact on them. Amelioration of infrastructures is of a high need because SARS-CoV-2, the pandemic, showed us, really made it clear what were the problems beforehand. But the problems beforehand, we kind of could cover. Now we have delivery room for women tested positive for SARS-CoV-2. We have a special CTG surveillance in intensive care units. This is what technically had to be ameliorated. So the consequences for pregnant women in Austria were irritation concerning risks for mothers and children, uncertainties towards wearing masks and right behavior, and unsettledness about the delivery process. The women were very nervous about having to have a mask when they were delivering vaginally and had to breathe heavily and so on and so on. And the mass media had to really play an important ethical role to not let the anxieties grow in the population. Irritation about mode of delivery. There was a debate, should all SARS-CoV-2 positive women have a C-section? SARS-CoV-2 infection as such is no indication for a C-section. Indications for C-sections are the same as in obstetrics anywhere. But when the woman is heavily ill, a C-section has to be performed because she cannot deliver vaginally when she is in such a danger, needing intubation or such. Mother protection regulations have come come only in November 22. They were very late. And until now, the pregnant women had no prioritization in the vaccination campaign. And with the help of the mayor in Vienna and the Council of Health and Social Affairs, we could prioritize the women in Vienna, the pregnant women in Vienna. Also, there were big anxieties about vertical transmission, and we have no experience in that. I have mentioned some case report where vertical transmission was observed. Comparison pregnant women, non-pregnant women of same age group. No studies with this regards were done. Now we have points to consider. The more previous diseases a woman has, the more unlikely is a conception. We have to also have this in mind when we talk about disease with SARS-CoV-2. The false hypotheses were women are less likely to fall ill more heavily. Or the next false hypothesis was younger people come less likely down with heavy symptoms. That all is not true for pregnant women. Pregnant women are a risk group for sicken more seriously when contract the infection. They have also additional risk when they are overweight. They have gestational diabetes mellitus, or they suffer from hypertension or other illnesses of the mother. The consequence of our findings were, and we were strongly supported by the VSEF registry of the United States, which told us in the United States, more than 70,000 pregnant women were in the vaccination program. And the outcome also told us, and here you have the results, told us that the outcomes of vaccination side effects, the results in vaccination side effects were not more problematic with women, with pregnant women, than with women who are not pregnant. And so Vienna became the first capital in Europe to prioritize pregnant women in the vaccination program. And we began with it May 20th, 2021. Finally, I have to tell you, finally. And it was very, very well received by the pregnant women. In the very first 2 days, more than 2,000 women got their first shot. Also, I have to tell you, you know this, of course, vaccination, we vaccinate with inactivated vaccines. Still, it is off-label use. We gave out a detailed information about risks and benefits and a detailed information sheet how to behave with side effects, especially with fever. The next plan of the City Council of Health and Social Affairs, Peter Hacker, is to offer family vaccination in Vienna in summer, because we begin our school year in autumn and we want our school year to perform as normal as possible. In order to protect the performance of the next school year in autumn, we would like the families to invite to vaccinate the children older than 12 years old. So these are the children for whom the vaccination is possible, and also this tell us many experts it should be desired when you outweigh risks and benefits. We really want to stop this pandemic, and I hope I could give you some insight how we deal with this pandemic for pregnant and delivering women in our Obstetrician department in Vienna. And I want to thank you for your attention on a very hot summer day in Salzburg.
Thank you. Thank you, Professor Barbara Meir. Thank you very much for that very insightful presentation on what happened in Vienna, which reflects, of course, Austria, and what you've done. And also, more importantly, the correlation and doing a study, bringing out some of the features that you saw with regards to pregnant, the COVID infection and in pregnant women. Thank you very much. And we will now, we will certainly have some more questions in the panel discussion from you. So let me now ask Professor Dr. Saska from Belgium. She is going to present, and important, her title is going to be The Impact of COVID-19 and Healthcare in Obstetrics and Gynecology. And she's going to talk to us about Belgium, the work that's done, and how they dealt with this in Belgium. Sashka, thank you very much, and over to you.
Thank you so much, Professor Russell. I will share now my screen, like that you can see my presentation. Here. Okay. So, hello everyone, dear chairman, dear colleagues, and dear participant. It's a pleasure to be here with you today. And I'm Sashka Gotevska. I'm a gynecologist and obstetrician working in the Schreck Hospital in Brussels. And I will speak about the impact of COVID that had it on the healthcare in OB/GYN in Belgium. With this health crisis that shut down the complete the global system and the entire global economy, the health was become really important for everyone, and everyone started to speak about the health. And I'm sorry, I have technical problem how I can go with the next one. Okay, as we all know, for the first time in the history, a health crisis has shut down the entire global economy, and that was painfully demonstrating how important it's the healthcare and related to the economy have become. So the people start thinking more about their health, and at the same time, it was the overflow of continuous information exacerbating with fear and influencing the political choices. To better deal with this situation, the European Commission set up a multidisciplinary and independent expert panel to provide scientific advice as an essential requirement to pursue the modern, responsive, and sustainable health politics. When speaking about the impact in OB/GYN, I'm thinking, my thinking is going for both, for doctors and the medical staff and for the patient. At the very beginning, when COVID started, the crisis for doctor was something really new, and it was some kind of stressful situation, and we were somehow overwhelmed with all this new information. And in organized interview by the medical unity, some doctors also said for the first time in their life, they had experienced some dose of fear for their own health, and especially because of the lack of protective material. It was better, and the adaptation helped in the process, and it was easier to deal during the second wave. For some of the staff, the psychological support was needed, and the hospital organized that. Information of COVID was rapidly changing, and it was important to stay in touch and refer to reliable source of information. The medical impact of COVID on the patient it was during the first wave, especially because all program activity and consultation and surgery, everything was completely stopped. There was the negative impact on oncological case, and there was the follow-up of pregnancy reduced to strict minimum according to the recommendation of our national association. Looking on the psychological impact, the pregnant women were more afraid of catching the virus. The COVID-19 pandemic has caused also care challenge, but also, however, simultaneously resulted in interruption of the clinical training and cessation of all elective work. It's COVID-19 has impacted the OB-GYN training in several ways, including the physical and the mental well-being. And it was encouraging that after the first wave, all the surgery being restarted nationwide and rebuilding surgical training. It was the moment that we also needed to think outside the box and how to utilize other modes of teaching and
Dr. Sashka, I think you're muted. We cannot hear you. Yeah, you're good. You're good.
But I am.
Please go ahead. Yeah.
It's okay now?
Yes.
Okay, perfect. So to better understand the medical impact in obstetrics, the Belgian obstetric surveillance system that usually register and analyze severe obstetrics complication in Belgium organized a national study about the COVID. And this is how the study was organized. So there was participation of 100 maternity around the country. Any pregnant woman and in the postpartum until 42 days were included with diagnosis of COVID-19 infection, who were admitted in the hospital in the period between March 20 and February 21. And there was monthly reporting and weekly during the high incidence period. This is the situation of Belgium on 11th of June with the different period. And we can see in at that moment, there are almost 1,200 cases reported and 820 were collected forms obtained and only 796 case included. One interim analysis in December 2020 was performed with a small number of cases, and conclusion may change when data gathered are completed. Please, I would ask you kindly to don't distribute the figure mentioned in this PowerPoint presentation, because this is still unpublished data at the time of this presentation. And this data was kindly provided to me by Dr. Anneke Verkutere from the Erasmus Hospital. So in this interim analysis, we can see that there were 352 cases included at that moment. And we can see that 15% of admission were COVID for COVID patient. Looking on the characteristic on the patient, about age, the country of birth, the BMI, or the comorbidity, we can see the more affected and admitted for COVID patients were the patients born in Africa, and the overweight and the obese patient are more predisposed to COVID infection and complication. Looking in the biggest part of admission were in the third trimester, and the discovery of COVID was during the hospitalization, and almost 60% were asymptomatic actually of all these patients. For the one with symptoms, fever and cough were the most common symptoms. Only 3% of reported cases were admitted to intensive care, and the several maternal morbidity was 3.7%. Looking on the obstetrical outcome, The majority of patients delivered vaginally without assistance. And there was also a few cesarean section, but we continue to respect the rules of cesarean section and vaginal delivery, like we usually do, except if the patient needed really a ventilation or stuff like that. And in that moment, it was obligate cesarean section. Looking on the fetal dismiss, it's 1.1%. And there is one case with chorioamnionitis and the PCR positive on the placenta. So the question is because we always knew that there was not transmission between the mother and the child. And this is the case that it's really needs more deep understanding of the process. In conclusion, the preliminary date, the conclusion may change with the time. That was a small number of cases. It was the beginning of the Belgian registration. So the principal risk factor were the country of birth with overweight and obesity. The principal symptoms for the COVID patient were cough and fever, so more easy symptomatic patient. And there was also a few ICU admission. The Professor Barbara already mentioned the things about the prematurity, so it's always under analysis, and also the question of the fetal demise. But since that moment of this analysis that was performed in December 2020, there are some worry because in March there were reported 2 cases with maternal morbidity and several cases with ECMO. And also this study from this UK group that say that pregnant women hospitalized in a rare period since the 117 variant become predominant were more likely to require respiratory support. So this was the short analysis about the situation, how it was in Belgium, and I thank you for your attention.
Thank you, Dr. Shashka. Thank you very much. That was very interesting, and your findings, although it was preliminary findings, seem to correlate with the others in terms of obesity and weight. I don't know whether, because I saw Barbara had gestational diabetes also as being one of the risk factors, and it seems to be around the world. In your group, in your study, did you see any correlation with the gestational diabetes?
If I come back in the more detail, all the comorbidities, especially with the diabetes, hypertension, all metabolic syndrome, actually it's a part of a risk factor for the for a more complicated COVID situation for this patient.
Very good. Thank you very much for that. Now I'm going to, we'll move to the international panel who will come into for the discussion. We'll ask Professor Mary Matthew, a very distinguished moderator, who's going to take over this part of it. But I've already introduced to you the 3 distinguished key presenters from Belgium, Vienna, Austria, and India. And just again, from the panel part, they will join the other international panelists from around the world. And one, of course, is Dr. Matthias Daniel Kyoko, who's a reproduction health specialist, obstetrics and gynecologist in the Moi Teaching and Referral Hospital in Kenya. And I'm delighted also to introduce to you Professor Richard Pesik from United States. He's a professor of obstetrics and gynecology and the director of the Center for Minimally Invasive Surgery and the co-director of the fellowship in the Advanced Gynecological Laparoscopy at the University of Louisville, Department of Obstetrics and Gynecology and Women's Health from USA. And the next distinguished panelist is Dr. Emily Faller, who is from the University of Strasbourg in Department of Obstetrics and Gynecology in France. And we'll have the next distinguished panelist is Professor Antonio Henriquez Franca Neto, who is the professor of obstetrics and gynecology at the Federal University of the Campina Grande in Brazil. And finally, we have another very distinguished obstetrician and gynecologist, Dr. Usha Harikumar from Ontario in Canada, who's going to join us. So here we've got these five very distinguished panelists, and then we have the three from India, Belgium, and Vienna joining, and over to Professor Mary Matthew, who's going to be take over the moderation of this part of the program.
Thank you, Dr. Russell, and may I congratulate all the three speakers. It is a wonderful, rich information that we got regarding obstetrics and gynae and the relation to COVID-19, the impacts and the statistics that we are seeing around the globe. May I request all our panelists to please switch on their mic, switch on their videos so that I don't miss anybody. Yeah, thank you very much. So before we go on to our speakers, just a few questions to our panelists. Just a few questions to our speakers. I'll start with Dr. Usha. Dr. Usha, you did mention about the problems that you had in the daily working of running the department, but you also teach medical students, you also teach postgraduate students. So how did you handle simultaneously your work as a obstetrician and gynecologist and the teaching aspect of your profession?
Almost all the sessions became virtual. Yeah. And so we definitely have a clear delineation. Even before, we used to take classes as well as manage these. Only that because we clubbed all the units together and we stopped doing the electives, so we were able to channelize these, but classes went on with the entire department taking care of. It's only that the clinical sessions we had to sort of slightly change and do it in a different pattern, so that they were able to understand, speaking to our own PGs who are acting like patients. It was like walking on a trapeze, but then we managed to do it.
Yeah, thank you, Dr. Usha. You seem to be able. I think this pandemic has taught us that we are resilient and able to adapt to the situation. I just want to let you know that the case fatality rate in India, according to ICMR, that is the Indian Council of Medical Research, in India during the first wave was about 0.7%. But in the second wave right now, we are having about 5.7%. What was your experience in terms of case fatality rate in Chennai in your institution?
If I'm going to be speaking of obs and gynae, fortunately, we just had 3 patients who were in the ICU, and one of them was very sick because she had gestational diabetes, but all 3 recovered. As far as the deaths of the patients in general who are getting admitted now, the death rates are pretty high. We do have about 7 to 8 deaths itself happening on a daily basis. But there's one thing that's very staring at our face, and all those patients who die are those who have not been vaccinated. We have not had deaths among the vaccinated ones, irrespective of the age. The age is from 26 to 76. Deaths have been higher.
Okay, so you're talking about obstetrics and gynae together, or is it just obstetrics?
In obstetrics, we have had no death.
No death at all. Okay, so you're talking about gynae, the gynae part. All right.
No, not the gynae in general. I was talking in general. General. Obs and gynae, we have not had any deaths.
Okay, right. Okay, no, I specifically want to know if there was anything.
No.
No, not at all. Okay, right. Thank you, Dr. Usha. Dr. Barbara, you said, I think Dr. Sashka has also kind of clarified that I'm a pathologist, and we have seen that the placenta does have the virus. Right now, I do have a baby who died, who was COVID positive. The mother was COVID positive, and the placenta also is showing, changes. They are not specific for the SARS-CoV-2, but the placenta is also showing some changes. So I think the possibility of transmission, a question that came in the chat box, is there, and the virus is seen in the placenta because we can detect it using immunohistochemical markers.
Yes, I have also information from Graz. There was one intrauterine fetal death and observed from a SARS-CoV-2 positive mother, and there also the placenta was infected. In our registry, we didn't observe this, but I think we will from time to time observe this, and we to collect all the data also from all over Austria, and we have some indication that the virus goes through the placenta. This was also a big concern of the vaccination of women, and we have to weigh risks and benefits.
Yes.
I was at the very beginning. I was thinking as a head of an Obgyn department, yeah, of course, we have young women delivering women. Young women are not so much at risks as the other population, but we learned that this is not at all true. And all the additional problems, overweight is a big problem. Also, I don't know whether this is the case in other parts of the world, but in Austria, the general population has gained weight because of the lockdown between 5 and 7 kilograms.
Yes.
And this is a huge weight gain. And this is also true for pregnant women. And because pregnant women tried to really be at home, not take any risk in going out and so on. And so this is a big problem.
Yeah, I just want all of you to know that there is an international perinatal outcome study that has been initiated from Canada and Australia, where they say that according to their study, the incidence of preterm birth is not that significant. But I think, Dr. Barbara, in your study, it looks like as a preterm births were much higher during the pandemic than.
Yeah, it's also a question of definition. We looked at preterm births below 34 weeks of gestation, and it was 3 times higher than with pregnant women who did not have SARS-CoV-2.
Yeah, I think you're correct in saying the definition is important. Yes. Thank you very much. Dr. Sasha, beautiful analysis you have. Were you able to look at the variants? Because you mentioned the B117 variant, but have you seen the various variants in the pregnant population, or is it just,
It was the study that I find it looking in the literature, but in our study, there is, in the second wave, we had more tests, and that was the lack of testing in the beginning. So we were not so specialized to know exactly. And I think that things become better and more sophisticated with the time, and it was the process of evolution and adaptation to the situation.
Yeah, so I think now we've moved from the B117, now they're terming it in alpha, beta, and now delta mutant viruses. So that is how we are going to call it. Yeah.
Okay.
Right. Thank you very much, Dr. Sashka. We'll move on to our panelists now. I'll start with Dr. Daniel from Kenya. Dr. Daniel?
Yes, hello everyone.
Yeah, thank you for joining this webinar, Dr. Daniel. You're from Kenya, and you are an obstetrician and gynecologist, and you specialize in reproductive health? Yes.
Yes.
So first, can you just give us a brief outline of what exactly is happening in Kenya regarding obstetrics and gynecology?
Okay, so generally we are a low resource country. I practice in the west part of Kenya in one of the hospitals known as the Moi Teaching and Referral Hospitals. We only have two large referral hospitals that offer specialized obstetric and gynecological care. And generally, we have just over 60% of our mothers who deliver in hospital. So we are basically one of the people, or one of the departments that has been largely affected by the COVID pandemic, because we've had, because of the fear and also due to more issues like government policy regarding control of movement and restrictions, we've had this number of 60% of mothers who deliver in hospitals actually coming down. And where we are currently is that thankfully, we've not had a very high burden of COVID-19 in the country. Currently, as per the latest statistics, we are at around 177,000 infections since the first case was reported, with around 3,000 deaths. So in terms of COVID-19 and its impact on the outcomes, and in terms of treatment and the provision of gynecological and obstetric services, we can say due to the relatively low numbers that we have compared to the rest of the world, we seem to be not doing very badly, but of course we've had other social impacts that have directly or indirectly impacted on the delivery of these services to our women. Thank you.
So are you seeing many preterm births, like as Dr. Sashka and Dr. Barbara said? Are you seeing a lot of preterm deliveries?
Well, I must say that where we are as a country in terms of our testing, in terms of testing capabilities for women with COVID-19, quite limited. We only tend to test women who have symptoms that are highly suggestive of COVID-19. And it's very difficult with the low numbers that we have to actually state whether the number of preterm births we have are actually due to COVID-19. At the center where I practice, which is the second largest center in obstetrics and gynecology in the country, we have not had any preterm births that we can attribute directly to infection with COVID-19.
Okay, so the policy there is that only if they are symptomatic, they undergo a testing, otherwise they don't.
Yes, previously we used to test all contacts of the patients or anybody who's been previously diagnosed with COVID-19. We used to do family testing and contact tracing, but due to paucity of resources, I think that policy has since changed. We only test the mothers who have symptoms that are related to COVID-19. So we no longer do mass testing, we only do selected testing for the various patients.
Okay, so if they become symptomatic during their stay in hospital, probably you'll be able to do a test.
Yes, we do test the ones in the hospital.
Okay, well, what is the acceptance of vaccination regarding, and what is the policy regarding vaccination in pregnant mother and breastfeeding, lactation?
Okay, thank you. So we adopted the FIGO WHO guidelines regarding the vaccination of pregnant mothers, which we generally encouraged all mothers to get vaccinated as long as they themselves were armed with the information that came with being with the risks and the amount of knowledge that we have as health practitioners regarding what will be the perceived side effects of these vaccines. So we generally have a national vaccination program that has been rolled out. Unfortunately, it's not a mass vaccination program. This program initially has been prioritized to healthcare workers. So any pregnant healthcare worker is likely to get vaccinated, but generally we are prioritizing healthcare workers first, and the armed forces and the police and the teachers. So we've not yet rolled out a nationwide public healthcare vaccination program currently.
Okay, Dr. Daniel, have you have any of your team become infected with the virus? So have you lost anyone?
Yes, unfortunately, we have lost two or three colleagues, I'd say. due to the COVID-19 disease. We've actually had quite an extensive sensitization process. We've had to do staff restructuring. We've had to thin down on the amount of, the number of people who are at hospital at any given time. And I think as some of the countries also have done, there was a period in which we also stopped the elective theaters that we were running at that time. So yes, unfortunately, we've had several or healthcare workers. As per the official reports, maybe in the country, we've had around 3,000 infections. In my department, we've had around, let's say around 20 of us infected, and that would include part of the obstetrics team, the gynecological team, and the nursing staff. And it's actually one of the reasons why, probably I'd say, one of the reasons why this offering of services has been affected, because even among healthcare workers, of course, with the information and sometimes even with the low supply of personal protective equipment, we've had sometimes, fear and uncertainty among the healthcare workers. So that's one of the psychosocial aspects of management of our patients that actually has had an impact on the provision of services to our obs-gyn patients. Yeah.
Yeah, but would your staff, was there hesitancy regarding vaccination, taking the vaccine?
Yes, I'd say yes, because currently we've had 151 people vaccinated in my center, and that is that's around 40% of the staff in the facility where I work. I think there's still been a bit of reluctance, I think, among the healthcare workers. We've not really been able to establish, though we are still trying to try to find out what is actually governing the various attitudes and the outlooks of the various healthcare workers toward the vaccination program.
Yeah. Thank you, Dr. Daniel. I'll come back to you. I'll just finish one round of all our panelists and then come back to you. Thank you very much. To all the panelists and speakers, if you wish to reply to the questions in the chat box, please go ahead and do so. If you have any material also or links you'd like to share, please do that. I'll come to Dr. Rashad. Dr. Rashad is from USA. Dr. Rashad, you're more of a laparoscopic surgeon.
Yes, thank you very much. I would like to thank all the presenters for this excellent review. What we have learned from this virus and pandemic is that the world is indeed a unique place that we all share, and all the borders are just artificially made by people. And indeed, the pandemic has taught us a lot of things. The life has completely changed around the globe. And most of these changes may be even permanent. We have learned how to adapt to this new situation. There are also some positive things that came out of this pandemic, such as we all learn how to use Zoom. That we apply in medicine the advantage of RNA vaccines that also will be used for treating cancer and many different things. Telemedicine and telehealth, that is also a great advantage. There have been changes in everyday life in different professions that people learn not to travel and go to work every day. There are huge repercussions in the real estate industry. People are moving out of big cities and going to the country. So overall, there are positive and negative changes. But unfortunately, also, a pandemic was politicized in many countries where politicians either denied people to use or did not encourage people to use masks to prevent the transmission. and also is being politicized some places, by anti-vaxxer groups against the vaccines. Overall, in the United States, that is country that has 330 million people, we had 35.5 million people that were infected, and unfortunately,
Dr. Rashad, just one moment. Can you tell us regarding obstetrics and gynecology, what were the changes that you saw with this pandemic?
Yeah, I'll come to that.
Okay.
I'll come to that. And overall, we had like 600,000 deaths from the pandemic. So when the pandemic first started and we realized in March and April that pandemic is indeed going to be, that this infection is indeed going to be a pandemic, the healthcare system in America reacted in a knee-jerk reaction, and we first kind of tried to shut down the facility, mostly to decrease we kind of stopped elective surgeries and allowed only emergency surgeries as well as labor and delivery, which is ongoing thing. But then we quickly learned by using certain measures such as testing for everybody, masking for everybody, early vaccination for the healthcare workers. After probably about 2 months of this slowdown, we were able to go on with business as usual. And we, in surgery, were able, first, we were testing every patient that came into the hospital to make sure that they were COVID negative. Those that were COVID positive were treated with special care, as mentioned by the previous speakers. And then everybody that is undergoing surgery these days has to be tested before surgery. So currently in America, we have, out of 330 million population, we have administer over 140 million vaccines. The people that are already fully vaccinated is over 140 million, which represents 41% of the population. And luckily now, President Biden, current president, has allowed 1 billion vaccines to be distributed throughout the world. Because the key thing is to realize that we all live in this world and the virus doesn't know the borders and does not recognize. So we all are in the same boat and everybody needs to be vaccinated. And the key thing for us as physicians is really to propagate vaccination and speak to the people that are denying vaccination. So that's the most important thing, to get the message across.
Thank you. Thank you, Dr. Rashad. I'll come back to you. I'll just go to the next speaker and come back to you. Dr. Emily, have you logged out or are you still there? Sorry, I know you have to go.
Yes, sorry.
Yeah, no, I'm sorry. Please go ahead. Yeah.
Thank you very much for the invitation. For me, my experience is similar than Vienna, because we have the first wave very soon, just 1 week after Italy. And in March last year, it was awful in my unit. We had a specific unit for obstetric patients, and I am a surgeon. I didn't operate during 2 months, and I became a pneumologist. So it was very strange and I have a lot of fear. But now, 1 year after, COVID is always here, and we work with it with less fear because we are all vaccinated. The vaccination is very, a lot of people have the vaccination, it's okay, and we have COVID pregnant women. We manage it, And we have a lot of United Care. No deaths, no woman dead.
Okay, no, you didn't have any deaths.
No, but
Okay,
we
and
had.
did you have preterm births?
Yes, last year we do C-section very soon because we were very afraid of oxygenation of the pregnant woman, and when the need of oxygenation was more than 8 liters, we were fear and we do a C-section. But now we have we put the patient pregnant in United Care, sometimes in ventral decubitus, and we don't do C-section. It's in the generally it's okay.
Okay. Thank you, Dr. Emily. Yeah, but do you practice privately or you're in a university,
Public.
right?
Yes, public.
Public. So you're also teaching along with your practice.
Yes.
Okay, right. Thank you very much, Emily. I know you have to go. Thank you.
Thank you.
Yeah. Can I ask Dr. Usha Harikumar? Dr. Usha Harikumar is from Canada. Dr. Usha, your experience regarding you are an obstetrician and gynecologist. Do you have any specialty?
Thank you, Dr. Mary, and I would like to thank you, Dr. Russell, for inviting me for this meeting. I'm attending it for the first time. Yes, I work in Toronto, part of a Scarborough Health Network. The hospital is called Centenary Hospital. Hello?
Yes.
Oh, yes, I think that's
yeah, we can hear you.
Okay. So we serve mostly in my area, mostly it's a South Asian population. I do obstetrics and gynecology. I do both. No subspecialization. I do gynecological surgeries, including laparoscopic surgeries, and also like probably 50-50 obstetrics. In my experience, so in Canada, actually, we are coming out of the third wave. During the first and second wave, the obstetric gynecology population were not much affected, but during the third wave, we had like more positive cases in obstetrics mainly. My practice has changed, like many other speakers said. We did more virtual visits in the office. In the labor room, we don't screen everybody. Only people who have symptoms or have been in contact with positive case, we screen and isolate them. The patients are asked to call ahead of time before they come. So one of the staff go and get them and get directly to an isolation room.
Sorry, Dr. Usha, do you test all pregnant women or those who are coming for obstetric and gynae care, or is it selective like Dr. Daniel said in Kenya?
For obstetric patients, we don't screen patients unless they have symptoms. Even if for elective C-sections, we don't screen them. Only for gynae cases, they have to have a test done for 3 days before, and we cancel. But cases come through the emergency department, we don't screen them.
So what were the challenges that you faced? What were the challenges?
Mostly the positive cases were not suspected, so we have to take every patient as positive unless proved otherwise. We were lucky compared to, I was hearing about Dr. Usha's presentation about the positive cases. I'm originally from Kerala, so the population of whole Canada is equivalent to the population of Kerala. So, and also we were lucky to have less number of cases compared to many other countries. But still, it was a challenge for patients as well as for us. For the staff, their psychological state, this big change came when it happened, and even for us, like wearing the PPE, the shield, and like we do the 24 hours call, and it was hard. But then the first wave, we were more scared. But then when it came to the third wave, when numbers were high, probably because of the time, when time passes, people get used to it. So we were more used to it. So it was not that bad. We didn't have any staff doctors got positive in my hospital. You were mentioning about the preterm birth. We actually found that in Canada there is some increase number of preterm births.
Preterm births, yeah.
Yeah. We didn't have any maternal deaths in our hospital. We have one hospital, Mount Sinai Hospital, where the high-risk pregnancy, moderate to severe disease patients, we transfer them there. So in my hospital as such, we didn't have any fatalities or severely affected patients. So,
what is the vaccination policy that you have there for?
So we are vaccinating, we are recommending vaccination for all pregnant and breastfeeding mothers. Any approved vaccine can be used. So currently we are giving the Pfizer and the Moderna vaccines, the mRNA vaccines. AstraZeneca was approved, but we are not giving that to the pregnant patients. And it's actually, in the beginning, people were reluctant, but once some people started taking vaccination, and then the numbers, like more than 75% of my patients have already vaccinated now. They are all taking it, like once they know other people have taken it.
So are you finding any changes in your, in any observation, stark observation in your practice regarding your patients?
Definitely.
Because they said obesity rate has increased, Barbara said. Have you seen these kind of changes in your practice?
Yes, yeah, I have seen, because patients working from home, they are, I've seen that. I mean, I didn't know the exact rate, but definitely people mentioned that they're gaining more weight. Okay. But mostly I found there's a psychological aspect of it. The stress they're going through, even though they don't have to go out, they have to come for appointments, they have to go out for the tests. So people find it scary to do that. And then they are more worried about the baby, like if it's going to affect the baby. So, and also during labor.
You didn't have much of bad outcomes in terms of, you know.
We had, yeah. We had a few patients really got sick. Actually, a couple of them, we didn't even know that they were COVID. They came with feeling unwell, didn't have a fever, and then tracing short fetal, abnormal fetal tracing, and then they found that positive, and from that point they got deteriorated and had to be transferred to the high-risk center. So there are a few, but there is no maternal deaths.
No matter. And have you noticed any mother to fetus transmission?
No, we haven't. There are cases like some of my postpartum patients, breastfeeding ones got it through contact, but not no vertical transmission reported.
But the babies are not positive.
Breastfeeding through the mother, yes, but not immediately, not during the.
The mother is breastfeeding and is positive, but is the baby also positive?
Baby was positive, yeah.
Okay, so there is some sort of transmission, but we don't know whether it's actually due to breastfeeding or otherwise.
Yeah.
All right, okay. Thank you very much. Another question, how did you manage all the communication between your patients other than virtual, when you want to communicate bad news or, how did you deal with the patient family? How was that done?
That was a big challenge, because we only allow patients to come to the hospital at the time of delivery. One person can come with them. So I have a few people who speak like Tamil, Hindi. So they usually depend on their husbands or partners to communicate. So we can't let the partner come in, then the number of patients in the waiting office get more. So over the phone, mostly over the phone, and I had to few times I had to go out to talk to them. I didn't want to bring more people in. So in rare occasions, we had to get more family member to come in. And it was psychologically too, like when patients come for delivery, sometimes they have an older child and the partner has to stay with them. So they have to be alone. And it was really challenging for patients.
All right. Thank you very much, Dr. Usha. I'll come back to you. I'll just go to Dr. Antonia. Dr. Antonia? Dr. Antonia is from Brazil. Is your
He's having some
internet,
problem.
can you hear? Are you okay with the net?
Sorry, my internet connection is unstable, so I'm not able to hear you clearly. So please speak slowly. I will try to answer you.
Okay, because it is a little bit erratic, what your line. Can you tell us the experience in Brazil as an obstetrician gynecologist?
Oh yeah, here in Brazil we have a huge problem with COVID-19. We are late. We are late on vaccination, as you know, and about obstetrics care. We have a huge mortality maternal rate. It's about 60 per 100,000 alive births, which is huge. For example, the WHO who recognizes a rate of 30 per 100,000 new births. Here we have the table. And about the COVID-19, we have lots of deaths here. In our experience here in Paraíba, we live in a small state in northeast Brazil. We have about 4 million people living here. And last year, 2020, we had 11 maternal deaths here in our state. Now, 2021, we already have, in just 6 months, 23 maternal deaths. So it's a huge rate, and it is a worry for everybody that works with pregnancy here. Now, the vaccination is spreading, thanks God, and the pregnants are receiving their vaccines, and we are hoping for a better time for our women.
Okay, Dr. Antonio, I just got the gist of what you said because it's breaking. You can correct me if I'm wrong. I heard that the maternal mortality is 60 per 1,000. Is that correct? That is very high.
Not 4,000, but for 100,000.
100,000. Okay.
Yeah.
Okay, and what about the neonatal mortality and preterm births in Brazil? Have they increased, and has the mortality increased?
Yeah, we have an increase in abortion and preterm labor, and also rising in newborn mortality.
Okay, so the outcomes in Brazil seem to be quite bad compared to the rest of the world.
Yeah.
Okay. Thank you, Dr. Antonio. I'll come back to you. I just want to bring in, if Dr. Vivek Madi is there, I'd like him to come on screen. Dr. Vivek, you're a private practitioner, and I want views regarding, Dr. Vivek is there?
Yes.
Dr. Vivek, you're a private practitioner, correct?
Yeah.
Yes. Yeah. So can you give us, and Dr. Vivek is from India, Chennai, can you give us your experience? Because majority of our speakers have been in universities and teaching colleges. What is your experience as a private obstetrician and gynecologist?
Yeah, as I my experience was that it was a very difficult period since the expectations were very high from patients. Their expectations of a better outcome and the care was definitely there, and so we had to raise up to that situation, and every outcome was supposed to be guaranteed, and that was very difficult for us. And we all worked well. My staff, especially, I had difficulty in getting all my staff together since the numbers were very less. We had to make arrangements for them to reach our place. These are the two difficulties which I had, and I'm happy we came out successfully, and I have not found it as a big challenge.
No, but what about regarding your,
the numbers of cases did come down, because obviously we had to refer certain difficult emergencies to higher centers.
Okay.
So, I had that communication with patient, because they suddenly had to accept other consultants in their treatment protocols. So that was difficult. I felt some of them were maybe not so satisfied when we had to transfer them to higher centers.
But did you face any hostility? Because India saw a lot of hostility among the, towards the healthcare workers.
No, because that's why I said I felt communication worked well with me, and I could communicate better to my opponents and whoever was there, so that I could convince them the difficulties I faced, and they accepted it. So that was, for me, was a very primary outcome.
Okay, so I suppose now everyone has adapted, and probably now the cases have picked up.
Yes.
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 Thank you, Dr. Vivek, for coming in. Thank you. I just want to go back to Dr. Usha. Dr. Usha from India. Both are from India, but Usha from the real India. Dr. Usha from Chennai. Dr. Usha, are you there?
Yes, ma'am.
Yeah, I just want to ask you regarding, I can't see you, Dr. Usha. Yeah, right. What about patients who underwent in vitro fertilization and their treatment, and what happened to them? Because obviously they were receiving some sort of care, right? Dr. Usha? I think she's gone. Okay. Are you there, Dr. Usha? All right. Okay. Dr. Vivek, can you stop? Yeah. Go ahead, Dr. Usha. Yeah.
Yeah, as far as patients who had already conceived with IVF, of course, we were following them up. But then I think those who were wanting to conceive, we weren't actually opening out reproductive medicine for quite some time.
Okay. All right. So was there an interruption in their care? Is that what you said?
No. See, there are two categories. One who are actually coming for the IVF, and for the those were like staggered. They were stalled. Okay. I mean, the department did not function. Okay. Those who had conceived obviously were having the antenatal.
Yeah, no, I was talking about those who were coming for treatment for IVF. So
no, we weren't open. We weren't open in the first wave. We closed down.
Okay, right. Thank you. Dr. Barbara, what about patients who were on IVF, on in vitro fertilization? And
in vitro fertilization in Austria is a private matter. Okay. So people receive support, but very often there are private institutes. Okay. What I can tell you about is we gave support to everyone. My main task is also to to do surgery on oncological patients. So we opened up surgery. We did not reduce our surgery capacities, but what I observed is that due to fears and mass media telling and showing what's going on with SARS-CoV-2 infection or might go on, people even with symptoms did not come to the hospital. So what we see now is that they come later. They had already symptoms, but they did not take them so seriously to come to the hospital or go to private practice, etc.
Yeah, I as a pathologist, I agree with you, because we saw a lot of gynae cases, ovarian cancers and uterine cancers that came in very late, at a very late stage. And I think Dr. Usha also probably will agree, both Dr. Usha from Chennai will agree that we saw cases which came quite late, and that was really sad, because they couldn't get care, or they delayed their visit to the outpatient department. Yes, that was an observation, Dr. Barbara. Thank you for bringing in the oncology service. I think it suffered quite badly during this COVID-19 pandemic. Patients suffered because of that. Dr. Daniel, what about your experience in Kenya regarding oncology?
So in Kenya, we actually have a bit of issues that were even existent before the pandemic came in. We only have 2 public centers in which specialized gynecological oncology services can be offered. And those 2 centers, there's one in Nairobi and the other one serves the western part of the country. And what we had during the COVID pandemic was one that patients were actually afraid of contacting COVID in the hospitals.
Yes.
So we actually saw that there was actually almost a reduction in almost half in terms of patients who are visiting the hospitals for both gynecology and also for general obstetric and gynecological reviews. The other issue that we had is there was for some time there was a cessation of movement directive by the government.
Yes.
And we had problems with access, especially patients not being able to access chemo, radio services, and that probably had an impact in terms of the outcomes that we could probably have seen, because still with the existent deficit in the services that we offered, there was also reduced access to these services, and this might have had a great impact in some of the outcomes we saw with the patients in the oncology department.
Yeah, I totally agree, because in India, we did have multiple lockdowns and patients were not able to access the care. I think that was the problem, and that resulted in delayed treatment and probably follow-up. Dr. Usha, your experience from Canada regarding oncology? You'll have to unmute yourself.
So oncology, we were, even though during lockdown, we were doing confirmed cancer cases, but then people with postmenopausal bleeding who needed to confirm the diagnosis were afraid to come to the hospital. We missed few cases because of that. And even I had a patient, you're a pathologist, so I have a patient who had a postmenopausal bleeding. Endometrial biopsy was negative, but she continued to have bleeding. She is 65 and she known to have fibroids. So there is a suspected leiomyosarcoma. The OR manager refused to do that surgery. She said, "Oh, it's not cancer. You can't do it." So I have to convince them through my department chief to this patient might have a cancer, and it came back as leiomyosarcoma. It's rare, but that patient would have gone into an advanced stage if we didn't do it. Yeah. And then even in emergency department, I had a few patients of ruptured ectopic ovarian torsion. They came late. I couldn't salvage the ovary, and one patient was near death. She lost so much blood, she didn't want to come to hospital because she's afraid to catch COVID from the hospital.
Okay, yeah, I think that was a general among patients, that they were scared to come to the hospital because they would catch the infection. Yeah, that was, I think, a universal thinking among people. Dr. Barbara, Dr. Sashka, sorry. Dr. Sashka, your experience on oncology? Cancer patients in, you're muted.
Yeah. Thank you. So I will say for both oncology and IVF. So in my hospital during the first wave from the complete lockdown, so everything was stopped. So all the plain surgery, even for oncology, everything was stopped for these 2 months, and IVF too. And during the second wave, we continued to operate. So the oncology practice continued, and also the IVF. So we have everything in our hospital, so everything complete to work normally, let's say, with all the precaution, of course, for disinfection, distance, and stuff.
No, but were you seeing cases that came late, Dr. Sashka?
In that opinion, yeah. Like in the other country also, there was also this fear of patient to come to the hospital, afraid to catch the disease or the virus. And also, but in Belgium, there is also a big screening program also. So we didn't have such advanced cancer, let's say. But
okay, good. So you didn't see that it as bad as the other countries where the patients came in late for services. Yeah. Thank you, Dr. Sashka. Dr. Antonio, are you still there? I hope your line is clear because Dr. Antonio, Dr. Rashad, are you there? I can't see his.
Yes, I'm still here.
Yeah, Dr. Rashad, what about oncology patients in your practice?
So as I mentioned before, we kind of stopped with elective surgeries for about 2 months.
Okay.
But then we quickly resumed all the services and started screening the patients. Overall, from the medical side, there was a very slight delay, but delays were more psychologically from the patient side because many of them feared to go to the hospital because of all this possible infections within the hospital.
Yeah.
But overall, there was not a big delay in GYN oncology nor GYN surgeries.
In accessing care and treatment, right?
Yes.
All right. Okay. Thank you, Dr. Rashad. I just want to wind this up by just asking our speakers. I'll start with Dr. Usha Harikumar. Dr. Usha, your last words, thoughts on what we have learned as what you have learned in your practice and how you are going to make what are the lessons that you've learned from this pandemic and how are we prepared for the next pandemic? And was there any improvement in the way obstetrics and gynecology was practiced?
This was a huge blow to all over the world. We always take life for granted, and this made us realize, okay, there are things like this can happen and change everything. The practice, the changes, when we first started the virtual appointments, it was really challenging and it was very hard. But then when we got used to it, and then now we are thinking probably like even once this pandemic is over, maybe some of these can be done virtually. We don't have to bring more patients in. Yeah. Only problem here, like we have the government, like we have a healthcare payment. So right now they are planning to stop the virtual payment. So then we may have to bring it back all in real. But we are trying to push it to get paid for virtual as well. So.
Are obstetrician gynecologists ready for the next pandemic?
We haven't even gotten over this one, so
okay.
Every time, like this is so everybody's like, what is the fourth wave coming? Because we are coming out of this third wave now. So every time we get out of this, like we are hoping, okay, this is it. But then after a few months comes the next wave. So hopefully this is it. No more pandemic.
Okay, thank you, Dr. Usha. Dr. Sashka, are we ready for the next? And what lessons have we learned? And are we doing well in terms of obstetrics and gynae practice?
think it was, this pandemic was a big school for all of us to rethink and to maybe rechange the priority in life and to try to optimize at maximum the way how we function.
Yes.
And I think with the process, we learn to adapt faster. And yes, if there is something like that, we will be more prepared to, it was approved with the second wave, yeah? We were acting really faster and adapting and continue to work. And maybe this is just the human characteristic, but it was important, yeah.
So Dr. Sashka, you're ready for the third wave, to take on the third wave?
No, I'm counting on the vaccine and I hope so that's gonna be finished.
All right, thank you. Dr. Barbara, your thoughts?
I am also very much interested in ethics in medicine. And what the pandemic told us is how resilient is a healthcare system in a special country, how much inclined people are to get vaccinated, also to protect other people who cannot get vaccinated, for instance. Also, what we have learned, especially in obstetrics, is pregnant and delivering women are of special concern. We have to really rethink the management.
Yes.
And also what I really think is also the ethics, not only medical ethics, but ethics in mass media, how to deal with information, how to give it, hand it over to people, how to listen to experts and politicians who are listening to us. This is a main thing, I guess, which is necessary to have medical ethics also all over the world, and that the world is one earth, and this is, also the climate change and so on. And so we know health care is one thing, but the healthy environment is a very necessary thing also to keep this in mind and to learn about not the small city or the small place you are in or you're working in, but to learn how to deal with a virus which captured the whole world.
Yes, that's true. A lot of learning has happened during this pandemic. Dr. Daniel, your thoughts?
So I think in my views and what I've actually encountered during this pandemic is that we still need to be at the forefront when it comes to advocating for our own patients. And as healthcare practitioners, we also need to, have the information that we're also going to give to the various stakeholders in our various governments in regards to decision making regarding reproductive health and obs and gyn and public health. Because in my particular situation, what probably affected outcomes a lot was the fact that our patients, our obs gyn patients, are a unique group of people who do not need to be lumped up when it comes to decision making. And we could have advocated more during this pandemic to have our patients exempted from various government directives, which might have rendered them a disservice during this pandemic. Yes.
Yeah.
Thank you.
So, ready for the next wave, Dr. Daniel?
To be honest, I think we are still plagued by the old issues that we've had before. Poor financing, poor access to healthcare.
Yeah, so I think a broken health system has damaged the health system even more. Probably decimated the health system. Yeah.
Yes, I think we were already hit when we were down. So it's actually a very difficult place to start from. But I think the first thing would be to start, the best place to start would be by repairing or trying to actually resuscitate our healthcare system.
Existing.
Yeah, and that will give us a bit of a chance when it comes to dealing with the pandemic.
Yeah, thank you, Dr. Daniel. I don't think Dr. Antonio is there, and I don't think Dr. Rashad also is there. So I will ask Dr. Usha to wind up. Usha, your thoughts?
I'm definitely not looking forward for a third wave, though we are pretty much prepared, having seen two waves in a very short gap. One thing is patients have become more tech savvy. The concept of hand wash and things
It's not
have
only
actually.
patients. It's not only patients, Dr. Usha. Even the healthcare workers,
Yes.
workforce also has become tech savvy now.
Tech savvy, hand wash. There are a few things that we have probably need to look at it positively, but definitely there is fatigue. There is fatigue in the minds of everybody, physical, mental. And see, so we only hope that we just get back to the good old days, really longing for it. And hopefully vaccination and things will change for the better. Let's keep hoping.
But a lot of things we have taken for granted now
Yes.
we have changed our views on that. So
Yes.
thank you very much. Thank you to all our speakers and all our panelists. It's been a wonderful learning experience. Thank you also for replying to the questions in the chat box. Some of the questions are basically very subject related, which I didn't really want to go into, and only you experts could answer that. So thank you for answering, and we hope that with this that we are prepared, yes, but we hope there won't be another wave. So thank you, and I will hand it over back to Dr. Russell.
Thank you, Mary. Thank you very much for your moderation today. And can I ask Derek, is there something you'd like to?
No, not really, Dr. Russell. Just would like to thank everyone for being very active on the chat box. We had a wonderful parallel session as always, and thank you, because some of the answers that were put there, I think, have added to our knowledge, what we were discussing in the main session. So thank you to all our experts and others who participated in that. It was really wonderful to see the interaction that went on. And of course, a wonderful discussion. My compliments to each of the speakers we had today. They went into so much detail. And of course, that whole feeling of solidarity has come through, that wherever we are in the world, we are facing the same problems, and we have to join together to find solutions. So thank you, everyone. It's been wonderful, this evening's interaction, and look forward to even more interesting sessions in the weeks and months ahead. Thank you, everyone.
Thank you, Derek. Let me now thank all the very distinguished speakers for the presentations and for the immense knowledge we gained from understanding how this has been, how we've traversed the discipline of obstetrics and gynecology in this COVID time. I want to thank all of you. I want to thank Dr. Sashka, who took a lot of trouble to coordinate with me to bring in some of our panelists as well as the speakers. Thank you, Sashka, Dr. Sashka, and also giving us a good picture of Belgium. And indeed, both together, we had a good idea of Europe with Austria, Belgium, and France taking part in this. I want to thank all the participants who have taken part here. We have, as always, if you look, we have colleagues from every part of the world, from who joined this program that we've been doing for some time now, and covering very important areas. Yes, Barbara, you want to say something?
I would like, thank you for having me once more. I would like to invite you all to a Congress, World Congress in Vienna, March 22. Yeah, and this is on psychosomatic medicine in gynecology and obstetrics. And the title of this Congress is Pandemic World, Woman, Family, Society. Thank you.
Thank you, Barbara. I think that's a good thing that we are hoping that this will all end and we'll be able to move across like we did before. In
And
fact,
I think, Dr. Barbara, you can send us the flyer so that we can send it out to everyone.
yes.
Yeah, will do. Thank you very much. And also we prepare this as a face-to-face congress, but also a congress on Zoom. Yeah.
Virtual. Now, hybrid. That's what we also have our program, the 14th World Conference on bioethics and health law in March in Portugal. Okay, in Porto. So it's a very good. If everything starts, we should be coming there. I note that psychosomatic. You're with the university. I saw that you're the president of the psychosomatic in psychosomatics in gynecology and obstetrics. Very good. Barbara, I'm a psychiatrist. I'm a professor of psychiatry, and certainly, yes, I understand and appreciate that. And you're with the Sigmund Freud University, is that right?
Yeah.
Yes.
Right.
So that's very interesting. Very good. So send us that. We'll have it. So all of you always invited to the 14th World Conference of Bioethics and Health Law.